kick it off. It's my distinct pleasure to introduce two epidemiologists whose names are both hard to pronounce, but who are leading experts in cancer, rural health, and health disparities research. Dr. Watanabe-Galloway is a professor in the Department of Epidemiology, co-director of the Bird Core of the IDEA CTR, and associate director of the Buffett Cancer Center's Community Outreach Core. Dr. Ratnapradipa, I'm sure I did that justice, is also an assistant professor in the Department of Epidemiology, associate member of the Buffett Cancer Center Prevention and Control Program, and serves on the Nebraska Cancer Registry Advisory Committee. Today, they're going to present to you findings from the Nebraska Community Cancer Needs Assessment. So without further ado, I will pass it off to them.
Okay, can everybody see the presentation mode or no?
Just the slides, not the presentation right now.
I need to redo this. How about this?
That looks good.
Okay, all right. Thank you for having us for Great Plains IDEA CTR presentation session. So we will be discussing the results from statewide cancer needs assessment. We are wrapping up. It's still going on through this October. It's a mixed method study using the secondary data and also focus group format. For the secondary data analysis, we are producing 70 plus page documents. So today we are just going to touch upon the main findings from the secondary data and ask Dr. Ratnapradipa to focus her discussions on our focus group or listening sessions. But if anybody is interested in the full report, let us know. That should become available next month. Thank you. Okay. So here is the outline. Before we are going to give you the main findings from the cancer needs assessment, I'm going to talk to you a little bit about the background of our office community outreach engagement. So Fred and Pamela Buffett Cancer Center catchment area is the entire state of Nebraska. And as most of you know, we are primarily rural state. Diversity-wise, close to 80% of the population is white, but over the past decade or so, we are seeing gradual increase in racial and ethnic diversity. And importantly, we have 4 federally recognized tribes in Nebraska. So Buffett Cancer Center is partially funded through National Cancer Institute, NCI. And it's one of the NCI's new requirement to establish the Office of Community Outreach and Engagement, because there is a strong recognition that academic cancer center is very good at doing the research, but often the research does not really focus on the catchment area needs of cancer. So that's the reason why NCI is now requiring all the accredited cancer center to establish community engagement office to reach out to the community and establish bi-directional relationship. So with that, we have 3 specific aims for community outreach and engagement, which I lead, to improve understanding of cancer burden in the catchment area, especially among underserved populations. Really to increase engagement with not only community organizations, but also healthcare systems and public health entities to promote evidence-based interventions and policies to prevent and control cancer in the state of Nebraska. And the last aim is to promote cancer clinical trials, which is traditionally poorly participated among underserved patient population, and to promote community-engaged research. So these are the three specific aims of our office. So statewide cancer needs assessment is one of the requirements by NCI. We are supposed to be using a lot of different existing data, such as tumor registry data, death certificate data, Buffett, that's statewide or the national CDC administered survey results, and so on and so forth. So that's the secondary data analysis part. We have been partnering with different organizations, including Nebraska Comprehensive Cancer Control Program, Nebraska Cancer Coalition, and different cancer centers, especially those in rural areas, to recruit participants for example, focus group studies, interpretation of the results, and so on and so forth. So the results are being already used to set the priorities for our office. And we are going to aggressively disseminate the results among researchers like yourself, so you can better understand the cancer needs in a state and incorporate the ideas into your research proposal, manuscript writing, and so on and so forth. Okay. So a little bit about secondary data analysis results, which is pretty descriptive in nature, but I hope it's going to be informative to you. So in 2022, according to American Cancer Society, over 11,000 Nebraskans are expected to be diagnosed with cancer. And the most common types of cancers include prostate, female breast, lung, colorectal, melanoma, urinary bladder, and so on and so forth. And mortality data, close reflection of incidence data, but pancreatic cancer is really making the third. And as some of you may know, that we just got funded for Pancreatic Cancer Center program. So we are really excited to promote not only research, but education and training around pancreatic cancer. Okay. So these are the most recent data from Nebraska Cancer Registry, as well as the national database that compiles data from 50 plus states from different cancer registry data. So the incidence rate is slightly higher in Nebraska, which is statistically significant. Mortality rate is about the same, about 150 per 100,000. So all of these rates are per 100,000 population. Like I described, the highest mortality is cancer, lung, prostate, colorectal, and pancreatic. And then cancers with the most racial disparities include prostate and colon, which I'm going to describe a little bit further in the next slide. But importantly, childhood CNS tumor rate is higher in Nebraska, in the US, and there are some evidence to support brain tumor rate might be significantly higher among pediatric population in Nebraska compared to the national average. So this is a breakdown by different racial ethnic groups. Incidence-wise, this is the overall incidence, by the way. African American in Nebraska has higher incidence rates compared to US national, the same as Native American. When you look at the mortality data, that is also the similar pattern you can see. So clearly, there are some cancer disparities experienced among Nebraskans. Yeah. And this is a snapshot from behavioral risk factor surveillance system data. The most recent data is 2020. So when you look at the colonoscopy use, clearly American Indian, Alaska Native, AIAN population has much lower and same as Hispanic in terms of the colorectal cancer screening use compared to Nebraska white and US white, which is about 70%. Adult smoking rate is far more among Native American population of about 40%. And adult obesity is higher in among African American. And in fact, Nebraska African American population has one of the highest obesity rate in the nation. And this is a map to show the incidence and mortality rates. This just simply show there are some variations of incidence and the mortality rates of cancer. And there are some rural communities with higher than the US Nebraska average rate. Okay. And I'm going to talk a little bit later, but pediatric cancer epidemiologic research is very important to better understand the causes of the disease, but I'm going to discuss a little bit more later on, so I'm going to reserve that information for later. Now I'm going to turn the sort of chair to Dr. Ratnapradipa about the listening session.
So as Dr. Watanabe-Galloway indicated, part of the overall needs assessment was reaching out to people in the community to get their perspectives. So we conducted a series of focus groups during 2020. We're going to use the terms focus groups and listening sessions interchangeably. It's the same concept. We were meeting with groups of people to get their perspectives. Specifically, we were meeting with cancer survivors and caregivers from different communities. So the listening sessions were developed in consultation with the Nebraska Cancer Coalition and the state's Comprehensive Cancer Control Program to develop a structured facilitation guide that included built-in polling questions or survey questions, as well as open-ended discussion questions. So it was a mixed methods approach even within the listening sessions. We heavily relied on community partners to assist with recruitment. And because these were conducted during COVID, the majority of the listening sessions were actually conducted via Zoom. There were a few that were conducted in person toward the latter part of when we were doing data collection, but for the most part, they were online, and that enabled us to have some cost and time savings in terms of the amount of resources that were going into the data collection. For the online sessions, poll questions could be answered with point and click options. You're all on Zoom. I'm sure you're familiar with Zoom polling. Some of the listening sessions were conducted with chat responses or actually getting verbal or visual responses from people. And that was completely based on technology preferences and familiarity with technology. And some people were using shared devices. And the results that follow the poll questions are typically going to be presented as figures, and the open-ended questions or discussion is going to primarily be presented as our qualitative analysis based on themes, sub-themes, and quotations. So here's an overview of the facilitation guide structured questions. They were really grouped into several different themes, focusing on community health status, sources of information about cancer and cancer prevention, positive and negative experiences along the cancer journey from symptom identification to diagnosis and treatment, with some discussion of follow-up care as well, although that was not specifically asked as part of the facilitation. We did specifically ask about some barriers that they experienced. And then we had the end part of the focus groups was specifically focused on colorectal cancer awareness and screening. And so as I present the results, those will be broken down into kind of general experiences and then colorectal cancer. So we did have 68 people that participated in the listening sessions. Listening sessions had a range of 3 to 11 participants in each session. Rural groups were recruited from Grand Island, Hastings, and North Platte, but also included participants from the Kearney area. And again, these were recruited from the local cancer centers. We had separate sessions for African American females and males based on input from the Community Advisory Board. And for the Hispanic focus groups, we had urban and rural. They were not differentiated by sex, but we didn't have any males that we were able to recruit, and so those are all females. And then we had sessions with Urban Indian Health Coalition in Lincoln and in Omaha, as well as the Ponca tribe. For those of you who are doing some quick mental math, you may have noticed that not all the numbers are adding up on this table. That's because individuals could be both survivors and caregivers of someone else who had cancer. Caregivers could care for more than one person with cancer, and people can have more than one type of cancer during their lifetime. And so we allowed people to have multiple responses for those different categories. Next slide, please. So this is a quick chart in terms of the breakdown between different groups of recruitment or populations that we were targeting, as well as the different types of cancers that were represented. You can see that breast cancer was the most commonly identified type of cancer among all of our participants, followed by colorectal and lung cancer, but there was a lot of variety in terms of the different cancers that were represented and even between different groups of populations. Next slide, please. So one of our very first polling question, or our first polling question as we introduced the topic of cancer in the community was to ask about the overall perception of health in the community. You can see that there was wide variation within and between the listening sessions about the perception of the community's overall health, but in general, the white rural participants had more favorable perceptions of community health than participants from other groups. For example, only participants in the Hispanic and Native American sessions indicated any type of poor response. And FAIR was much higher among the non-white participants, non-rural participants. Next slide, please. The importance of cancer as a community concern was the next question that we asked participants. And you can see that across groups, cancer was viewed as moderately or very important within all of these different subpopulation communities. As part of outreach planning efforts, we wanted to know how people were receiving information about cancer prevention and cancer services. And so for this polling question, participants could select multiple results. So again, they're not going to add up to 100%. We can see that different populations have different methods of receiving cancer and prevention information. In general, healthcare provider was cited most often across groups. A notable exception was in the LGBTQ community, in which family or friend was the most common source of information. And 83% of the African American participants also received cancer information from friends and family. Nowhere was not one of our initial response categories, but in the Hispanic focus groups, people did indicate that they didn't have any information about cancer, and so this was added. A quarter of the Hispanic participants said that they had no information about cancer. So this slide is actually from the qualitative or the open-ended discussion questions, but we did notice some general patterns when we were talking to participants or asking them to share their experiences with cancer diagnosis. And so we were able to create these themes in terms of how people went about identifying that they had cancer. So the first theme is through routine healthcare or screening. So if people indicated that they had gone in for a mammogram, a colonoscopy, routine physicals or blood work, that was classified as routine healthcare or screening. Those who had routine care or cancer screening typically had really coordinated care in terms of being referred for follow-up diagnostic testing, biopsy, notification of results, and transfer to specialized care, although there were some very poignant examples when this did not happen. Participants who received care for symptoms that were not initially identified as being cancer-related often related this experience as being misdiagnosed or having a delayed diagnosis. Examples of this would be participants that reported seeking care for symptoms that weren't adequately resolved, and only through their persistence in expressing pain or complaints of symptoms were they eventually referred for cancer testing. Examples of this would be abdominal pain, bone pain, symptoms of dizziness, headaches, and those types of things. So this included a wide range of cancers that included treatment, again, for bone pain, abdominal pain, neurological problems, women who felt lumps in their breasts, but their primary care doctors thought it couldn't be cancer due to the patient's age or other demographic profile. And then the final category is self-identification. And these are people who actually thought that they had cancer, reported it to their regular care physician. And this would be people who noticed lumps forming and set up an appointment with primary care and then were referred for testing. Some of these individuals experienced lack of coordinated care, delayed biopsy results, but most across all of these different categories, most of the participants indicated that they had positive experiences with timely referral for diagnosis. Care coordination really encapsulates the theme of how easy it was for people to move between primary care and specialist care, between different specialty cancer providers. Patient navigation came up quite often. Participants indicated that they had a lot of different appointments and tests, and so anything that could help them keep track of those appointments and the test results was viewed as care coordination in a successful or positive way. Notably, some of our rural and Hispanic participants indicated that things weren't connected well from primary care to specialty care, or that even within specialty care that some of the doctors weren't coordinating very well with each other, resulting in duplicated testing and really complex, complicated appointment management on the part of the cancer patient. Next slide. Communication really is focusing on shared decision-making between the doctor and the patient's family. One example of a Native American participant indicated that her mother-in-law was diagnosed and didn't receive enough information. She did receive enough information, excuse me. There were other cases where people indicated that they weren't allowed to ask questions of the doctor, or that the doctor was very brusque or short with them. And so that would be examples of negative examples of communication issues. Particularly in the Hispanic group, language issues came up in terms of communication. I'm going to let you read those quotes yourselves, but there were some really poignant examples of people who had poor communication with their healthcare providers due to both the healthcare provider not taking them seriously or because of language barriers. Next slide, please. Finances is a known barrier to cancer care and cancer services. And so cancer centers and community foundations and pharmacies often have programs in place to help assist with some of those financial barriers. Our participants indicated that they had financial assistance in the form of gas cards, hotel discounts, meal reimbursement or meal discounts. Some of the rural participants indicated that there was a community organization that helped with housekeeping services. Pharmacies can often help with medication costs. But again, some of our minority populations are facing barriers to accessing even some of these in-place services. A Hispanic participant indicated that she was not able to access any of those supportive services because she hadn't lived in the state for more than 5 years. People who have undocumented status or illegal status often have barriers. And within the African American community, there were indications that not everybody has health insurance or knows how to apply for some of those assistance programs. This being Nebraska, we did consider distance as a barrier as well, particularly for the rural populations. And that's not just the white rural Nebraskans, that also applies to the Native Americans and the Hispanic focus groups. So some people were appreciative of having local cancer centers so that they didn't have to travel so far. But even with those local cancer centers, some people are still traveling long distances, up to 4 hours in some cases. As I mentioned when talking about some of the previous slides, supportive services play a really important part in terms of support from a formal perspective, but also support from the community. One rural participant, a rural male, indicated that he found one of the advantages to being from a small town was that the community itself was his support group. He shared examples of people in the community wearing t-shirts to show that kind of moral support for him going through his cancer journey, as well as people in the community coming over and helping him take care of his yard so that when he wasn't able to do that, people in the community volunteered to help. Churches are also sources of spiritual support. This was particularly noted among multiple participants from the Hispanic focus groups. And among African-American participants, My Sister's Keeper here in Omaha is a huge support. It's specifically focused on breast cancer, but it is well known within the African-American community and provides a vital role. Not everybody has access to these community-based supports. A rural participant, a female, indicated that she had cancer at the same time that her husband had cancer, and because she didn't have any other supports, she delayed her own cancer treatment so that she could take care of her husband as he passed. Hispanic participants also indicated that they had difficulty in finding services to educate about how to cope with cancer and language appropriate, cultural appropriate hospice services. And there was a perception that there is more support services available for women, but not for men. And that was noted particularly in the Hispanic population. Excuse me. Unfortunately, discrimination does happen even in cancer care. So there were stories shared by Native Americans where she had some grandparents who were Native and some who were white, and she noticed differences in how they were treated in their cancer journey. Some Hispanic participants indicated being treated badly even at check-in. So check-in staff being really rude to them, treating them badly because the husband had forgotten to bring his identification card with him. And the treatment was so noticeable that the husband, the wife, and their interpreter all commented to each other about how disrespectful they were being treated. Discrimination is also a common theme in the LGBTQ group, where there's a lot of anxiety regarding disclosure of their status as being gender or sexual minority. And so one individual shared the example of working with a provider that was all bubbly and happy and very friendly until they found out that the person accompanying the patient was the patient's wife and that they were a lesbian couple. And then she indicated that the demeanor changed like that, like a switch flipped, and that there was really noticeable differences in terms of how that provider was interacting with the patient and the patient's support. That leads us to issues of kind of historical mistrust of the medical profession in general. And so this was noted by African-American participants that there's a lot of historical angst about interacting with the health community and the health system. Noted by both African-American and Hispanic participants was a lack of people who looked and sounded like they did. So lack of diversity within our medical profession, our healthcare providers, so that people aren't interacting with doctors who look and sound like them. And again, noted by LGBTQ participant, this is particularly important when people are going in for emergency treatments. This individual indicated that in general, they like to kind of pre-screen healthcare providers, so dentists, doctors, et cetera, to see who's queer friendly. So the idea of being operated on by someone I didn't know anything about was really terrifying, and not knowing if disclosure of that person's sexual identity would somehow impact life or death care. Next slide. So there are cultural aspects that need to be taken into account when we are putting together outreach or engagement activities. Hispanic and African American community members indicated, as well as Native American community members. So all three of those groups indicated that they have a cultural bias about going to see healthcare providers until symptoms are so severe that they can't be ignored. And so that leads to a tendency for delayed care, delayed treatment, more severe cancer when it is diagnosed. Other cultural aspects to consider are that within the Native American community, some people do have a preference for traditional healings because they're non-invasive. And so people are okay if it's something on the surface or if it's an exam that's on the surface, but as soon as it's something invasive, they have a preference for going back to those traditional healing techniques. There are, sorry, I can go back one more session. There's also a reluctance to talk about cancer in some of these communities. So it's kind of unspoken, and so people don't really know what to expect or don't have a lot of information about it. Okay, thank you. So moving into the colorectal cancer portion of the listening session results, if you'll go to the next slide. We started out this discussion by a polling question asking what types of cancer, colorectal cancer screening the participants had heard about before as a way of introducing the topic of colorectal cancer. And so after the polling question, the discussion identified a lot of confusion about some of the stool-based tests. And this was common across listening sessions. So we know that this slide has misclassification error on the stool-based testing. To kind of highlight this misclassification, several people had heard of Cologuard but didn't know how to classify it. They knew it was a stool-based test, but they didn't recognize that it was a DNA test. In general, perceptions of stool-based testing was mixed. Some participants preferred it to the invasiveness of the colonoscopy procedure, but a few participants were really put off by the idea of collecting stool-based samples. In terms of awareness, again, colonoscopy is far and away the most recognized type of colorectal cancer screening. And that moves us into the next slide, which is perceptions of colorectal cancer. It was really hard to disentangle perceptions of colorectal cancer from perceptions of colorectal cancer screening, particularly colonoscopy, but we did our best to try to disentangle that. Examples of perceptions of colorectal cancer in general is that it's a disease that kills. It's something nobody likes to talk about. It's something that people are scared of or have denial about. They'd rather not know about it. Some people thought that it's a type of cancer that only certain people get, or that they can't get it, they're not at risk for it. In multiple focus groups, although this quote is specifically from the rural focus group, there's a perception that it's an old person's disease and nobody wants to think of themselves as old. And so there's this kind of denial about the need to get colorectal cancer screening. Colorectal cancer screening, again, most of these comments focused on colonoscopy, which was the most widely known screening. There were comments about it being a joke, about people not taking it seriously. Most of the comments related to the invasive aspects of colonoscopy and the preparation for colonoscopy, so the bowel prep. Kind of a reluctance about it being a male thing. I don't need to do that. I don't want to do that. It's going to somehow make a man less manly to have that invasive procedure. But in general, there's a lot of embarrassment and kind of sexual connotation joking about colonoscopies that are a put off to a lot of the participants. In terms of screening awareness in general, there are a lot of comments about, I hadn't even thought about it. I didn't think I needed it. What is it? Not having heard of it before. Being unfamiliar with options beyond colonoscopy. For those who had heard of stool-based tests, concern about the accuracy of the tests. But in general, there was a lack of familiarity with all of the available options for colorectal cancer screening. And so when people hear colorectal cancer screening, they almost always think colonoscopy and don't consider the other less invasive matters. There were some participants who worked in healthcare settings or worked as part of public health outreach efforts, such as Every Woman Matters, who were very well informed about colorectal cancer screening and the different testing methods. But the opposite was more common, where people knew little to nothing about the topic. In terms of colorectal cancer screening barriers, again, most of these are focusing on colonoscopy, which is the gold standard and best known method of screening. But because it's an invasive procedure, people have to go in, they have to have anesthesia, they don't want to have to take time off of work. The bowel prep is a day or two before the procedure, and so people think that's an inconvenience. And so those are all perceptions that are barriers to people getting screening. It can also be very costly to have colonoscopy, even for people who have insurance, just the way it's billed. So that takes us to the role of healthcare providers. Repeatedly across focus groups, we heard words such as the healthcare provider insisting or harassing or getting on people about needing to have the colonoscopy. And so patients or participants indicated that when their healthcare providers were really insistent and harassed them about needing to get that screening procedure, that they eventually would get the screening procedure. On the other hand, there were some participants who said that their doctor didn't recommend that they get the screening and they didn't know anything about the screening, even if they were age appropriate for it. So kind of the takeaway from this is that doctors need to repeatedly and forcefully push screening for their patients to really think that it's important enough to do. We did ask for suggestions about outreach efforts and education efforts. And so the African American community indicated that before we can focus on colorectal cancer or cancer screening in general, there needs to be education in the Black community to improve trust in the medical community. Examples would be diversifying the medical profession, but also having people who have been through that cancer experience advocating and telling stories and testimonials so that they have hope that there is treatment, that they understand that it's better to get screened earlier rather than waiting until they have really severe symptoms. And so repeatedly across focus groups, there was this idea that messaging from cancer survivors or people who were currently patients undergoing treatment was probably the best way of really getting the community to understand the importance of the issue. Within the Hispanic community, they did indicate that group education, such as meetings, talks at churches, schools, and community centers would be one route of community health education. And the Native American community wanted more involvement in the community about educational awareness programs. Social media was mentioned by the African and American and the LGBTQ groups as other avenues of spreading the word about cancer screening. But it's important to note that it was only mentioned by those two groups, and the rural community had very different ideas. The rural white community had very different ideas about ways of sharing that information. There also needs to be provider information. So people indicated that there's some physician bias in terms of one type of screening over the other, or that some providers don't really have that shared decision-making model and aren't providing options for colorectal cancer screening. They're telling people to go get the colonoscopy, and only when people refuse do they present the other alternatives, such as stool-based testing. So really educating the providers about the different options and how to educate their patients about the pros and cons, and using that shared decision-making model. And navigators can play an important role in that as well. So this concludes the summary of the listening session results. I know it was really quick. We had a lot of results, but if you would like more information about them, I would refer you to the COE's website, where we do have session reports that provide additional themes and representative quotes specific to each population that we were targeting.
Thank you, Kendra. So I'm just going to wrap up this session by talking to you all about importance of outreach and engagement from academic center like ourselves. So COE has been reaching out and working with different community organizations, healthcare system, and public health entities to start doing cancer prevention and control presentations. So if any of you are interested in signing up as a presenter and speak to different community organizations or population groups, please reach out to me. You might have specific expertise you can share with us: nutrition, physical activity, obesity, specific cancer type. We would love to have you sign up as potential speaker. We are going to start lining up lunch and learn sessions as the COVID is, hopefully dying down. But we are engaging with the communities in the different venues, and examples are given on this slide. In case you are not aware, Buffett Cancer Center has this database, or the registry of different cancer. The information here might be a little bit outdated, but as I was speaking to ICARE2 director, there were 87 sites signed up for ICARE2. So this is the database which collects surveys and biospecimen information from cancer patients seen at the UNMC and other participating sites. It's a very powerful tool with many patients, 30,000 patients enrolled. But it's been somewhat underutilized. So I just want you to be aware of this resource. And again, if you have any question, you can directly contact Buffett or me, so I can get you connected to the person who can direct you to explain how you can get the data from this database. And as I promised to you, pediatric cancer is under-recognized, but an important healthcare issue, public health issue in the state of Nebraska. And one example of community-engaged research could be a pediatric cancer watershed study, which is led by Dr. Eleanor Rogan of the Environmental Agricultural Occupational Health Department. They've been collecting the water samples, and this is an example of how we can work with the community to address cancer related issues in the state of Nebraska. So this is the website we have set up to disseminate the various reports and infographics. Some of them are presented today, but there are tons more information you can find. And we are happy to tell you that we already have 2 manuscripts accepted from the cancer needs assessment. So there are actually scientific and research related activities going on through the cancer needs assessment as well. So that should conclude, presentation, and we can take any questions the audience might have. Or you guys can email us.
In your listening sessions, did you catalog cancer screening rates among your attendees as well, to like kind of cross tabulate opinions with their actual screening practices?
No, we did not. we tried to keep the listening sessions to 60 minutes. And so it was a lot to fit into the 60 minutes, but we appreciate that idea. There are a lot of other questions that would have been really helpful to ask, but maybe going forward.
Yeah. And as far as the listening session goes, you probably noticed LGBTQ, we only had 3 participants. That's after working more than 3 to 4 months trying to recruit. We reach out to many different organizations which work with LGBTQ community members. And we had several people sign up for the session, but only 3 people showed up. We will continue our effort to reach out to different population groups, including LGBTQ and eventually refugee and immigrant populations. But, you know, we need to wrap up this cancer needs assessment sometime. So we probably write the case series report rather than, you know, traditional focus group analysis, especially for LGBTQ. But there's such a rich information provided by only 3. Discrimination in particular is a big theme in this population group. So it's an important topic, but unfortunately we are not able to provide details today.
And then we have a question in chat. Can you elaborate a little more about why the rural white community had different views from African American and LGBTQ communities towards social media as a way to get information?
I think in part it's probably the age distribution of the participants as well. The rural population was not specifically targeted as being a white population, although that's what the demographic of the participants that ended up being in that group were. But they were talking about radio blitz and newspapers. And so just different ways of getting information that might be generational more so than racial.
Yeah, but I believe there are some research evidence to show African American and Hispanic populations and patient population might be the heavy users of social media. I think Facebook in particular has been used by underserved patient group more than white. So there is already evidence there, not just for cancer, but in general.
And within the Native American groups were the ones that were conducted in person. And even when we were in the group, there was a lot of talk about how they were on Facebook constantly. And so although they didn't mention that as an outreach educational tool, they did say that that was a good way for them to connect within their community.
Yeah. And then technology preference was pretty strongly shown when we reach out to tribal and urban Indian programs. They really strongly recommended us to do in-person listening sessions instead of Zoom, because that's just the way to talk to people, not through online methods. Although we ended up doing one Zoom or the hybrid of it, but so there is a cultural difference right there for the preference of use of technology. Okay, Kendra.
Great question. So in the chat, are there mental health services in place for when people receive a cancer diagnosis? How about mental health support for the caregiver? So this really varies depending on how the person is getting their diagnosis. So there were examples of people in the Hispanic community who were receiving care at One World, which is a federally qualified health center, where they were offered mental health counseling at the time of diagnosis. But for the vast majority of people, that did not seem to be the case. They were typically getting a phone call to either schedule an in-person visit with their primary care physician or the nurse, or they were actually getting that diagnosis over the phone from either the provider or the nurse at the local healthcare clinic. And that was one of the things that came up in the focus groups as a need would be, it would be great if people could have somebody just pop in and say, hey, do you need to talk about this, as they're getting this really heavy diagnosis. But there were examples of people who were an hour away from home on the road driving when they got the call from the primary care provider saying, hey, you have cancer. And they're driving home for an hour with this really heavy burden with no one to talk to about it. So the way that people are notified is definitely somewhere that there could be room for improvement. So question, did you further classify caregivers such as spouse, child, parent, hired assistant, etc.? Not formally. A lot of the caregivers were spouses, whether that was same-sex or non-same-sex couples. But there were lots of examples of a child who cared for an adult parent, or even friends caring for other friends. And so we did not limit what the caregiver definition was. I don't think we had any examples of hired assistants. It was typically family member with some friends. So going back to the previous question about mental health support for the caregiver, that was something that several people mentioned would be helpful if there was support groups for caregivers and not just for the cancer patient. It does not seem to be widely offered.
So I guess as a learning opportunity, did you have to level set with different communities since they were kind of interviewed together in these listening sessions? Were some communities more willing to participate, or were there like issues with groupthink if it started out negative or positive, and any lessons learned from that experience?
And Shinobu, you're welcome to jump in here too. Within each individual focus session that we held, I didn't notice any kind of group think. There were definitely examples where people were sharing their experiences. Maybe they had a really negative experience with a particular oncologist or radiation oncologist and talked about that particular doctor's really poor interpersonal communication skills, and other people would jump in and say, yeah, I had that doctor too, and I had the same experience. We did try to keep people away from complaining about specific providers. But we really opened it up and asked them, please share your experience with your cancer journey, share both positives and negatives. And sometimes we would go back and say, you know, we've heard a lot of positives where they're negative examples, or vice versa. We've heard some negative examples where they're positive examples. So we did try using prompting and probing questions to keep it kind of level.
Thank you.
And again, we are going to disseminate pretty extensive report based on the secondary data analysis results. And I'm going to work with Heather and Gerald to make sure it can become available for IDS-CTR members. Thank you for the opportunity for presentation today.
And we do want to make sure that we send a huge thank you to all of the partners and the participants that made this possible. I know they're not on this call, but it could not have been done without the support of a lot of people.
Including Dr. Kiona King. Thank you very much.
Yeah, the Center for Reducing Health Disparities at UNMC helped do some of the, helped do some of the racial and ethnic minority focus groups.
Thank you very much.
Great. Thank you both. All right. Have a good afternoon. Thanks.